So my presentation today is on the use of a second generation BTK inhibitor. Its name is BGB-3111. It now also has a proper name, which is zanubrutinib. And it is the results of this drug in phase 1 study in patients with mantle cell lymphoma and aggressive diffuse large B-cell lymphoma, follicular lymphoma, and marginal zone lymphoma. So this drug, the phase 1 study had been ongoing for about 3 years now. We've previously reported that the drug is very effective and has a good tolerance profile in patients with chronic lymphocytic leukemia and Waldenstrom's macroglobulinemia. But today's presentation is the first time that we've broken out the rest of the non-Hodgkin's data and presented them in a more mature format. So just a bit of background about the drug. So as I said, it's a second generation ibrutinib. It's more specific to ibrutinib because it is more specific against BTK and doesn't take out as many of the other off-target enzymes. It has a potential for reduced off-target effects. And indeed, when we did the phase 1 dose escalation, we took the dose all the way up from 40 milligrams, which is the equivalent as full dose ibrutinib, up to a dose of 320 milligrams. And we had very good tolerance. So we're talking about drug levels that are approximately 8 to 10 times higher than ibrutinib. And really the question for us is, if you intensify the degree of BTK inhibition, use ibrutinib at very high doses, so to speak, whether you can improve the clinical responses. And the one disease where we've really seen this were in patients with Waldenstrom's macroglobulinemia, where we were getting very deep responses, seem to be deeper than we would expect for similar population receiving ibrutinib, which is why there's now a registration study comparing zanubrutinib and ibrutinib in Waldenstrom's. Now, back to today's presentation. So we're talking about the results in the phase 1 in patients with non-Hodgkin's lymphoma. So in mantle cell lymphoma, not surprisingly, there's a very high response rate. These are patients who predominantly have relapsed refractory disease, have failed 2 prior lines of treatment. The response rate was 88%, and 25% of patients were in complete remission. These data are probably similar to other BTK inhibitors such as ibrutinib and acalabrutinib, but certainly confirms that this drug is active in mantle cell lymphoma. We also present data in follicular lymphoma, which is a disease that's fairly typically resistant to ibrutinib, and the response rates to zanubrutinib is 41%, with a few patients being in complete remission. So we do get a response in follicular lymphoma. Once again, very hard to compare between, across different trials, single arm trials, but perhaps a little bit more activity than we expect for ibrutinib. For diffuse large B-cell lymphoma, similar to ibrutinib, there was a 41% response rate. So about a third of patients responded with diffuse large B-cell lymphoma, and the response duration is probably a little bit longer than what is published in ibrutinib. So in conclusion, what we drew from the efficacy data was that in most of the non-Hodgkin subtypes, that the drug is at least as good as ibrutinib. There's some types, like I said, in Waldenstrom's, where it may be even a bit better. In terms of tolerance, certainly the side effects are very benign. So for ibrutinib, typically we would expect half the patients to have some degree of bruising or bleeding, albeit minor in nature, and with this drug is about a quarter. And then with ibrutinib, we would normally expect about 5 to 10% atrial fibrillation rate, and so far we're seeing about 2 to 3% atrial fibrillation rate. So just like other drugs like acalabrutinib, which are more specific, which may have more reduced side effects, we're getting signals that maybe we're seeing the same thing, that with a more specific drug, we can get to higher drug levels and get reduced side effects. But of course, that needs to be confirmed in randomized studies.